So today we have Po Chow. Po Chow is the Senior Vice President of Finance and Population Health and Physician Services at RWJBarnabas Health. He has a very extensive CV here, but I'm just going to give you the highlights. He has worked with the Department of Health and Human Services in the past and now is on their advisory board. He's a graduate of George Washington University, holds a master's in public health and MS from the University of Texas, and has 2 PhDs, one a DRPH in Health Services Research and a PhD in Management and Policy Sciences. So with that, I'll turn it over to Po on MAC and MIPS. This is MACRA and MIPS. This is a very complex program, and I think he can help us make some sense of it. So with that, Po Chow.
Thank you for that generous
Sure.
introduction. Good afternoon. Thank you for having me here today. So today we'll cover the MACRA and MIPS. What I hope to do is provide you a overview of MACRA and MIPS with the learning objectives that you see up on the screen. I'll give you a quick background and get you to differentiate the difference between MACRA, MIPS, and also advanced alternative payment models. What I want to also talk to you about is implications related to these quality programs and what the proposed changes are for 2019 as well. So as you all know, CMS has been quickly adopting alternative payment models in the US. The 2018 goal of 50% of US healthcare in alternative payment models were actually accomplished a year earlier than expected in 2017. The goal for 2025 is obviously to make sure that 90% of US healthcare has adopted alternative payment models in the system. The goal is obviously to modify the traditional fee-for-service to a payment model that focuses on better care, smarter spending, and healthier people as well. CMS has deployed many different programs, models in the past few years from accountable care organizations. Some of y'all are participating in the Comprehensive Primary Care Plus, yet others have started to focus on advanced bundle payment initiatives as of the 1st of October as well. But all of these models have been distilled into different types of models. The ones that I'll focus today for today's grand round will be MACRA, focusing on MIPS details as well as advanced APMs. So MACRA was passed October 14th of 2016. It does focus on the Medicare fee-for-service program. As you know, the Medicare fee-for-service program is becoming a little bit more complex. There are quality metrics that are required. There's a whole host of different things that CMS has deployed associated with the program. I'll start first. Some of y'all may recall the old PQRS, the value modifier, and the meaningful use requirement. So just after you learned what all of that meant, CMS decided to change that into MACRA. So MACRA, as you know, is a new program that CMS has deployed. It will sunset the legacy program. This year is the last year for PQRS, value modifier, and meaningful use as well. But with MACRA, 2 tracks exist. The first one, from a provider's choice, is to either manage performance, which is MIPS. We'll talk a little bit more about MIPS and the different requirements associated with that. Or the alternative model is to manage risk, and we'll talk a little bit more about advanced alternative payment models as well. So within the Medicare Access and CHIP Reauthorization Act of 2015, the first option is obviously to manage performance with the Merit-Based Incentive Payment System, or MIPS, which is the terminology that's used in the marketplace. With MIPS, and let me just pause this a quick second. With MIPS, the way that it's structured is that there is a host of eligible clinicians that will fall under this. So I suspect that most of you will fall under this category, and that is from physician assistants, MP, CNS, CRNAs, and practices that have these clinicians associated with these clinicians as well. So the way that it's structured is that MIPS has 4 basic components. It's similar to what you have seen before in PQRS, value modifier, and the different changes that CMS has. It starts with quality, cost, clinical improvement, as well as the last one, which is the promoting interoperability, which is really the IT portion of MIPS as well. You weigh all of these scores and you come up with a composite score, and this is how CMS measures your performance, and this is how they will impact or provide the adjustment to your Medicare fee-for-service reimbursement. So the weights of the different components, the categories are 50% in the quality space, 25% in the IT or the old meaningful use, 15% in the improvement activities, and then 10% in the cost, which is the old value-based model or value modifier as well. There are some exceptions. So if you're first year entrant to the Medicare fee-for-service program, you're exempt from it. To the extent that you're participating in an advanced alternative payment model, you're also exempt from it. And then the last piece is that to the extent that you meet the low volume threshold, which is either 90,000 in Part B, 90 or less, or 200 or less patients in a Medicare fee-for-service space. Okay? From a MIPS performance perspective, we'll talk about year 2. So we're actually in year 2 of the program, just so that you understand the calendar aspects of MIPS. So the way that it's structured is that 2018 is the second measurement period for the program. It starts January 1 until December 31st. After the measurement period is completed, by March 31st of next year, you have to submit your quality metrics, all of the different performance metrics for CMS to start evaluating your score. And then you receive feedback. That's typically in the summer or early fall. Some of y'all have received the 2017 version this year. And then to the extent that there are no changes or no contestations, then CMS implements that fee schedule the following January of 2020. So remember that the measurement period of 2018 is then impacted in 2020, January 1st of 2020, right? So our first measurement year, performance year 1 was 2017. You see that the fee schedule adjustment for the 2017 period will be January of 2019. And because we're in 2018, based on the calendar that you see above, that means that the impact of the fee schedule adjustment will occur January 1st of 2020. So remember, it's essentially not quite a 2-year delay just because the measurement period ends at the end of this year. There is the evaluation period in 2019, and therefore after the evaluation period, then the fee schedule hits the following January 1st of 2020. So the MIPS adjustments, as a reminder, 2018 impacted in 2020. But for the 2018 measurement period, that means that your fee schedule can be adjusted +5 or -5. For those folks that have a +5, to the extent that there are more penalties, if you will, or adjustments downward, then there are adjustments upward, then CMS will allow you to multiply that up to 3 times as well. But that depends on that national calculation as well. Okay? So remember, 4 different categories that you need to focus on. The first one is quality. That means that you need to submit 6 quality measures for a full 12-month period. That includes 1 outcome measures. If the outcome measures doesn't exist for you, then a high priority metric is submitted instead. So one example of an outcome measure that's also a high priority measure is hemoglobin A1C. So CMS is looking for that outcome metric associated with your patients. We'll talk about different ways to submit data. One of the options is a web submission. To the extent that you do a web submission, you do need to report all 15 quality metrics as well. We'll talk about where to get the information from CMS. CMS today has over 300, 400 quality metrics today. You can select your specialty. You will give you options for you to choose metrics from, and we'll cover some of those as well. There is a bonus aspect to the quality metrics to the extent that you submit 2 or more outcomes or high priority metrics. You do receive a bonus in the calculation in the way that they weigh the program. But remember that if you only do 1, it doesn't count. It has to be 2 or more, okay? And then from a cost perspective, cost is typically calculated, so there's no submission for cost. CMS will basically take your claims data based on the Medicare beneficiary spending and calculate that for you as well. The next category is the improvement activities. Those you have to complete for a minimum of a 90-day period. 2 high-weighted activities or 1 weighted activities. I have examples of those, but there is currently about 113 improvement activities that are listed as options for you to consider. The medium one is to expand practice access or do advanced care planning, and the high-weighted activity is something similar to a CDC training on CDC guidelines for prescribing opioids. So those are some examples of improvement activities that you can participate in as well. The last one is the IT metric. Last year was called the Advancing Care Information, or ACI. CMS decided to change that to make more meaningful use of the terminology, just because it was confusing different folks, thinking that it was a clinical metric when it was more about IT, right? So this is based on your certified EHR technology that's available to you. Most of you, I'm sure, are using different EMRs and technology solutions. Depending on that certification, whether it's a 2014 certification, 2015 certification, or newer, there are different requirements associated with that. But these are things such as e-prescribing, access, patient portal access, and other types of interoperability associated with technology as well. From a data submission, you do have a few different options for you to consider. Many folks do submit that through their existing EHR. Most EHRs that are qualified have the ability to submit that on your behalf. Some of them charge you a little bit more than others, but it all depends on the EHR that is currently deployed in your practice. There are different ways for you to submit. You can submit through an Excel file. You can submit through a zip file. There is a web interface version of it. To the extent that you're participating in other programs, there are also different ways for you to submit it. You can submit it either as an individual or you can submit it as a group. So most folks will typically take a look at what their measurement is individually and what their measurement is collectively as a group. And to the extent that one helps the other, folks will typically submit it in a fashion that gives them the highest number of points, and you receive the highest benefit from the calculations and the weights associated with that. There are some MIPS exceptions. So for 2018, to the extent that you meet any of these criteria, if you're a hospital-based physician where 75% of your encounters are non-patient facing, then there are different adjustments that are made to those providers. So you're essentially in a different formula. Your weights are re-weighted differently. There are some specialties that CMS considers to be non-patient facing. One example of that is radiology. So depending on your specialty, you may have a different special status. But these are waivers or exceptions that have to be completed and submitted as well, except for the ones that CMS recognizes that are truly non-patient facing as well, okay? There's also some hardship exemptions that you can submit for. Some of those are based on small practices or geography or lack of internet connectivity. And in certain cases, they are extreme and uncontrollable circumstances. When we had the challenge with different natural events occurring in Texas and Florida and other parts of the country like Puerto Rico, there was exceptions that CMS provided as well, hardship exceptions. All right, I want to talk a little bit more about advanced alternative payment models. So these are for clinicians that are a little bit more advanced in their practice. Part of the challenge in this model is that you do have to take financial risk, and I'll explain that piece for you as well. So in the advanced APM model, to the extent that you qualify and you're meeting those requirements, it means that you are MIPS. You can exempt from MIPS, but that means that you're actually participating in a different care model in an advanced alternative payment model. What that means is for 2018, there are different requirements, but if 25% of your Medicare payments or if 20% of your patients are in this model, then you automatically receive a 5% incentive as well. And then, and remember that for the 2018 measurement period, it goes into effect in 2020 as well. So one of the pieces that I wanted to explain to you is the different components of this. So just because you are participating in a alternative payment model doesn't mean that it's an advanced alternative payment model. And just because you're in an advanced alternative payment model doesn't mean that you're a qualified participant. So I'll define these for you as well, just so that you have a good understanding of these as well. So an alternative payment model, an example of that would be a Medicare shared savings program. So you may be participating in a MSSP program, but to the extent that it's a track one or upside only, it means that it's simply an APM and not an advanced APM. One of the requirements for an advanced APM is that you take downside risks. So if you're doing a track 3 MSSP, or if you're doing a next generation ACO, then because there's downside risk in that model, then you qualified for a advanced alternative payment model. Talk a little bit more about the qualified participants as well. Okay, so we covered the advanced APM models. So the advanced APM models for 2018 are what you see listed here. They are Bundled Payment Care Initiative Advanced. They are the Comprehensive ESRD Care Program, and a whole host of others that meet. For the most part, some of those hold true for 2019 as well, because Vermont, none of us are practicing in Vermont, but if you're in a Vermont model as well, Medicare ACO model, you would also qualify for those as well. Okay. So one of the aspects that I wanted to make sure that there is clarification on as well, just because you're participating in these models, if you're not a qualified participant, you're still ineligible to meet some of these models, right? And that is that in order for you to qualify, not only do you need to participate in an advanced APM model, but you yourself also have to become a qualified participant. So what does a qualified participant mean? Qualified participant means that you're still required to meet the same EHR requirements that everybody's supposed to meet, but you're also supposed to take financial risk. So the first piece within those models is that depending on the year, so we're showing 2018, so that means, as I indicated before, that 25% of your Medicare fee-for-service payments have to be in that model. If it's not in that model, you don't qualify, or 20% of those patients. Next year, that benchmark does go up, so it will become, instead of 25% of those payments, it becomes 50% of their payments, or 35% of your patients as well. But the piece that becomes a little bit more challenging is that you do have to take risk. And nominal risk, as you see here, is not only taking financial risk, but making sure that the total risk that you're taking qualifies for that nominal risk definition. That basically means that you do have to take downside risk, and that downside risk has to be sizable enough that CMS deems that you have enough skin in the game to become a qualified participant. Okay? So that's the basic components of MACRA with MIPS, the Merit Incentive Payment Systems, as well as the Advanced APM systems. So there are some changes that CMS has proposed for 2019. Everything is not finalized quite yet, but I'm sure that it will soon be finalized. From a simplification perspective, they're going to be changing the category to support EHRs a little bit better. They are going to move different clinicians to smaller sets of objective and measures. I think that will be helpful as well. And then they'll allow different collection of quality performance as well. The bonus points scoring methodology that we currently have, they're proposing that we retain those as well. They're proposing the same low threshold volume that we have today in 2018 to be extended to 2019. We're asking people, or they're proposing that folks opt in to participating in MIPS, and then there's some small practice concessions that CMS is trying to create allowances for as well.